All right, we're live here. There we go. We are live on Facebook and YouTube with people already joining the room. We love to see it, so let's not keep them waiting. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNet's program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade. I've been working with CCF for over 10 years now, folks, over a decade, creating all kinds of video content, live video series, Q&A sessions like the one you'll watch today, patient-centric documentaries, dense treatment-based videos, all kinds of videos, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. If you're new to this community, if you're new to the show, I want to say welcome. And a little bit about this show, I feel very strongly like the value is twofold. One, the information hopefully answers to some of your questions that you'll get from our guests. And two, the shared experiences and the shared stories from within the community. I can't tell you how supportive this net community is. It's like nothing I've seen before. And I say that to say, if you are new to this journey, look at the comments. People are already probably chiming in, saying hello and where they're from. I encourage you to do the same thing. Introduce yourself, ask questions, get the thoughts, opinions, and experiences of these other folks. Embrace the community, and I assure you it will embrace you back. That's one of the best thing about the folks in this community is how well educated they are, how much they advocate for themselves and their quality of life, and you can glean wisdom from those experiences as well. Before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because we couldn't do the show without their support, but we do have this disclaimer from them before we get started. That is that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF or LACNets do not endorse or promote any of the views, opinions, or information provided in the presentation, or not necessarily. So, audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that last line is really the crux of it. That's the takeaway. We're going to try to give you some general advice to your questions and help you along this journey, but each case of this disease is unique, so take that information back to your home team and make the best plan and path forward for you and your unique case. Okay, I'm very excited with our partnership with LACNets this year. It's brought a couple of great things. One, the first thing was the support line, which you can reach for anybody that needs support, anybody affected by nets at lacnets.org/support line. And the other thing is a whole new host of new guests for Luncheon with the Experts, much like the one that we have today. So I would like to welcome to the show for the first time, Dr. Gagandeep Singh. Dr. Singh, how are you?
I'm good. Thank you for having me. Appreciate it, Ray.
Absolutely. Affectionately known by his peers as Gogs.
That's correct.
Is
Yeah.
that correct?
Yeah.
Dr. Singh, for those, I alluded to this community, this net community, which includes, specialists like yourself and support group leaders and all different kinds of folks. Tell us what, where you work, what you do, and what role you fill in that community.
All right. So I'm a cancer specialist, a surgeon, and I've been a faculty surgeon for a little over 20 years now. But my journey started a long time ago. I'm originally from Bombay, India. I trained at the biggest cancer center and the busiest cancer center back in Bombay. It was still called Bombay when I left. It's called Mumbai now.
Indeed.
Uh, and, after finishing my super specialty training in cancer surgery, after general surgery, I was looking to see what did I really miss out on. Now, based on the population in India, we come out extremely well trained as long as you go to the right institutions in the country. And this was one of the busiest institutions in the country. So I wanted to, improve my expertise in liver surgery And so that's how my journey started westward. I wasn't sure I was going to end up in the US. That was not a part of the whole thing. So I stopped at a super specialty center in Paris at René Descartes University Hôpital Cochin. I spent a year there in a liver unit. After that, I moved to the Royal Liverpool University Hospital. And then, to cut the chase and the story short, I ended up in the United States, ended up recertifying, and then started my faculty career as a hepatobiliary and pancreatic cancer surgeon
Hmm.
at the USC Keck School of Medicine in Los Angeles. So that's and then from there, I was there for about 5 years. I moved for a couple of years as the director of the Liver and Pancreas Cancer Center at the John Wayne Cancer Institute. Unfortunately, that institute is no longer there. It has changed names in several hands afterwards. And then in 2010, I got recruited by City of Hope Comprehensive Cancer Center in Los Angeles to head their surgical oncology, i.e., cancer surgery program, and build their liver and pancreas program. And so that's my movement. And within City of Hope, I recently moved to Phoenix, City of Hope, to build a surgical presence in Phoenix. So I've been here just around 2 months or so with the intent of putting the Phoenix Comprehensive Cancer Center on the map as well over the next couple of years.
Before we started the show, I was talking to you about that transition, and you seemed pretty excited about it. Can you tell us a little bit about why that excitement is within you?
Yeah, for me, it was almost like coming home. So what you
Mm.
don't know is, no matter which part of the world you're trained in, whether it's Europe, Australia, Asia, when you come to the United States, you have to redo a couple of years of your training.
Okay.
And I ended up doing my couple of years of training here in Phoenix at the Maricopa County Hospital. And at that time, it was called Maricopa. Today, it's called Valley Wise. And there's an unmet need for comprehensive cancer care. You know what I mean? Structurally, cancer care should be a team effort. Not everything is healed by steel, as I say. It's not surgery that is the answer for everything. You've got to have this multidisciplinary approach. You've got to have a team approach. You've got to have surgeons. You've got to have medical oncologists. You've got to have radiation oncologists. And then you have a smattering of interventional gastroenterologists, interventional radiologists that form that team, basically. And although there are places within Phoenix that are doing some of this, but I think nothing to the extent that City of Hope has done in Los Angeles. And as you know, we're now the third biggest cancer center in the country. And so it was with that same intent and same mindset that, the institution, the leadership, asked if I would take this opportunity to sort of build Phoenix. So for me, it was like coming back home. We love Phoenix. So I've been here, like I said, about 2 months. And we're working now to build a team. I already have most of the elements in place, but I'm trying to recruit a few more people to get that comprehensive team in place.
This is a little bit of a vague question, but when you're building that multidisciplinary team, you're building this one, right? So what types of people, not necessarily their roles, but maybe more their mindset, are you looking for? Because the point that you're making is so crucial for this disease to have, and even the way, like I noticed, you didn't say this precisely, but as a surgeon, you said that surgery is not necessarily the best option for everyone, right?
Right.
So you have an open mind clearly about how we approach these things. Is that what you're looking like from your counterparts on this team, or how do you find the best people to recruit for this?
Ring, that's a good question. It's about sequencing
Ah,
more than, it shouldn't be that if you see a surgeon first, he operates. It
right.
shouldn't be that you see a chemotherapy doctor and he puts you on chemo. It's got to be a team approach. What's going to make the best impact for that patient? That's
Mm.
critical as I look at it. Some of the cancers need chemotherapy up front
Mhm.
before you go to the operating room. Some of the cancers need surgery up front and then chemotherapy and maybe radiation up front. So every disease is a team effort when it comes down to cancer. Okay. And I think that is critical here, basically. And I think within that, I think even having a great GI team behind you that can do a lot of things now endoscopically, a great interventional radiology team behind you that can do a lot of things under CT guidance, it's an important decision to cause less harm to the patient, provide longevity with quality of life. And that's how I look at it. The intent is to get cure, but we don't always get cure. So it becomes living with the disease. And sometimes it's making some of these cancers a chronic process where people have 20, 30, 40 years of normal life with it.
Thank you so much. I appreciate that. Folks, I see some questions coming in already. That is great. If you have them queued up in your mind, go ahead and start sending them. We're going to chip away at them as quickly as we can. Just a reminder, if we don't get to all your questions, you can always follow up at the support line, and we have the show every 2 weeks this year. To help us get to your questions, ask them in kind of generic, smaller chunks. It's a little bit easier to navigate just in this format. They can't be too case specific, just because we don't know your specific case. If we need some extra information, we'll ask you, we'll prompt you. And there is no limit to how many questions you can ask. So feel free to chime in and go ahead and start sending those questions in. I see a few in the queue already. One last question from me, Dr. Singh. I'm always interested in the current, I don't want to say status, but I'm asking about the right now in the Indian institutions. Where are they in terms of how they approach nets, in terms of their experience with nets? Because it varies from country to country. We have some people on here, by the way, we've got S from Belize and Monica from Brazil tuning in. So we have some people that are like, there are no net specialists in my country.
Right.
And then there are some where they're further along, perhaps, might not be a great expression, than the US, right? In Europe, they've had other things going. So where does India stand in that?
Well, so India is, 1.4 billion and increasing.
Yeah.
So, and actually, the statistics are more world statistics, more United States statistics, and we have a better idea from that. So, something that's really interesting. So, and I'm going to backtrack a touch. And what actually got me into nets, I've been practicing for over 20 years now. But it was almost about 15 years ago when I saw a 19-year-old young girl with a freshman in college with a mass in the head of the pancreas. Okay, she was not jaundiced, but she had a mass in the head of the pancreas. And at that time, they biopsied it a couple times, but were unable to get tissue for it. So obviously it was a solid mass, and it prompted me that I need to take this out. But what she also had were 2 spots within the liver. So, and that was seen on the CT scan at that point. And again, at that point, we didn't have the gallium-68 dotatate PET scans for neuroendocrine tumors. So we did what was called an octreotide scan. And those 2 spots within the liver lit up as a neuroendocrine tumor. Okay. And so that prompted me saying, okay, I've got a neuroendocrine tumor in the head of the pancreas, and I've got spots in the liver. What's the best way to approach this? Naturally, as a surgeon, I said, let's go after this. She's 19. We've got to give her the best shot at this. We presented at a local tumor board. She had fairly extensive disease with involvement of some of the veins, which were completely occluded. And it's surprising that she was only 19 at that time. So and it's a true story. And actually, she's probably attended some of these lectures at LACNet, and we've had these patient discussion forums. She's now, 17 or 18 years out from the surgery and doing really well with no evidence of recurrence, knock on wood. So we ended up starting with a Whipple. And when I cut the pancreas, the margin was positive. So I went a little bit beyond the neck on the of the pancreas, and I cut again, and the margin was positive. So there was disease creeping along the length of the pancreas, which we could not actually see. All right.
Wow.
And then I cut again, and the third time the margin was still positive. So at that point, I just broke scrub. I went out and talked to the parents, very educated, super nice. And the father's response was, straight, what's the way to get complete cancer out? And I said, the only way to do it is total pancreatectomy. And he said, what's the biggest side effect? And I said, she's going to be a brittle diabetic and she'll have some digestive issues. He says, if you can clear her, go for it. Okay. And so did the mother. And so I come back in, I finish up, she ends up with a total pancreatectomy, and I remove the 2 spots within the liver. And then she did really well after surgery. She was out of the hospital in 5 to 7 days, and then has been following with me for the last 14, 15 years now, basically. So this was back in 2007. But what that stirred in my mind was, what is going on in this young population for them to develop a cancer at this point? And it's a little convoluted answer to your question, but it's going to take you through the history of
No,
NETs
I
and
appreciate
the
it.
way I've actually approached it over the last 15 years. So a year later, I had another young boy now with 18 years old. So the question was, are these syndromic? Are there genetic things? Or is it a change in the environment that we're in, basically? Now, she had no genetic, nothing in the gene screen. The young boy ended up having VHL in the gene screen. And he was 18 at the time when he got his Whipple pancreatic duodenectomy. But that started a whole thought process in my mind at City of Hope is, are these patients all coming from certain areas within the United States? Now, what I started off first was to see the trend of neuroendocrine tumors. And the best way for me to interrogate that was by looking at the California Cancer Registry. And what I noticed was, in the last 40 years, our statistician said the incidence of neuroendocrine tumors has gone up 7-fold across California, whereas most of the cancers have plateaued. So there's something going on. And there's a lot more that I did with the statistician, which is a 10-year process. But the most recent numbers that came out of the United Kingdom, it is now the second most prevalent disease in the United Kingdom. So I'm giving you numbers just to state the fact that we are now beginning to find more and more of these neuroendocrine tumors, and the actual incidence is perhaps increasing to a certain extent as the population increases, but our diagnostic tools have gotten a lot better and we're able to pick these up now. Okay, so that gives you an idea that
Yeah.
the numbers are still actually increasing. And I've done a whole bunch of population studies, pollution studies with our statistician, looking at grid lines. And I can keep talking about this for hours. But let's answer some of the
Yeah,
questions.
yeah, we'll answer some questions. No, I appreciate that very much. I'm always intrigued and curious what drives people to this. And I like that you told this story. That was very helpful, especially about a younger patient, because I think that we've done a good job of dismantling this belief. But historically, NETs has been perceived as an older person's disease. And we tell a lot of stories of younger people with NETs because we know that's not true. So I think it's also important that you illustrated that as well for folks. So yeah, let's get to some questions. First one comes in from Dorothy. Dorothy says, CT scan the other day showed no evidence of disease. My last surgery was 3.5 years ago. With NED, why do I still have numerous flushing episodes each day and all kinds of digestive problems?
I love these questions. So a CT scan is good, but an MRI is better. Okay. And I've actually looked at data, we've randomized it, we've done it blinded radiologists, and then put that together, and an MRI is better. So I would encourage you to get an MRI with EOVIST contrast. I'll spell EOVIST, it's EOVIST. And the most important thing on that scan would be to get a 20-minute delay. Okay. This will tell you if there is small disease within the liver that is not being picked up on a CT scan. Okay. Now, CTs are great. I love CT scans. They're very good for fine precision, anatomic detail, but they certainly are not the best test for liver metastases. One of the first things when you are still having these flushing-like symptoms is the question, is there disease that we're not picking up? Okay. And small disease, even within the liver, is not going to be picked up on your gallium-68 scan sometimes, but the MRI will localize disease up to 2 to 3 millimeters. And if you got multitude of spots, you will be able to see some of those. So I'd encourage you to get that. I would also encourage you to get a bunch of hormone markers. I'm sure you're getting your chromogranin levels. You need a 24-hour, an HIAA serum serotonin level, which is a little bit more non-specific. But I would encourage you to see an endocrinologist, get a bunch of these hormone levels drawn out, because usually the carcinoid syndrome is from two hormones that are significantly elevated. One is serotonin, the other histamine. So you need somebody from good endocrinology who's going to monitor some of these, and a non-specific marker, which is actually not totally non-specific, but if it's elevated, you can use it really well in your follow-up with patients, which is the chromogranin A level. So I would recommend you do that.
Got it. Thank you. And thanks for your question, Dorothy. Question from Eileen. No, I missed that. Catherine, rather. Question from Catherine. What is the best form of imaging to show small tumors in the pancreas?
So I actually think both CT and MRI are good for the pancreas, so they're complementary.
Okay.
But the best imaging of the pancreas is with the endoscopic ultrasound. Okay. So if there's a history of, familial history, which is less than 5% of the patients with neuroendocrine tumors today, as you know, 95% of them are sporadic events. In the 5% where you would like to be screened, or if you think there's a high chance that you might be having something going on the pancreas, I would encourage you to reach out to your gastroenterologist for an endoscopic ultrasound. The reason I say endoscopic ultrasound is because these can pick up tumors, up to about 2 or 3 millimeters in size within the pancreas itself. The reason CT scans and MRIs are sort of not perfect for picking up these smaller tumors within the pancreas, because if you think about it, the pancreas is almost like a slab of butter. And the density difference between that and some of the fat around it is sometimes very hard to resolve, because remember, it's a computerized either magnetic rays or radiologic X-rays that are going through your body, and the computer at the back that's reading the diffraction and then telling you what's going on within the body. So when things are really small, they are not necessarily going to be picked up either on an MRI or a CT scan. Now, I'm going to put in a little important point over here. Even if you have a very small tumor in the pancreas, does it really need to be taken out? That's the question that we should be asking. Is if it's less than a centimeter in size and you're 70 years old, I would probably recommend and refrain from actually any form of surgical intervention. And we can go into that later on in the talk. I'm sure there'll be more questions on that.
Got it. Thank you. And thanks for your question, Catherine. Question from our friend Pat. What should we know about histotrypsy? This question is very popular these days, and you're
Right.
smiling.
So,
So,
yeah. So, I am personally also looking into it at this point. I'm not one who runs into these new therapies right off the bat. I would rather approach liver metastases with something which is the standard of care rather than something that's experimental. Okay, so that's number one. Number two, the most important thing to remember about histotrypsy, this is really ultrasonic waves. So they put the probe on the body, they localize the tumor, and they basically break the tumor up with these high frequency ultrasonic waves. It is great. It would probably be good for single tumors. But if you got 30 tumors in the liver, this is not going to work. And neuroendocrine is often not about one or two tumors. It's usually about many tumors within the liver. Now, let's say you've had a liver resection and there's only one area that's actually growing, or there's one area that is concerning. Yes, I think you can make a case to do histotrypsy for that. The other thing, at this point, the data is very weak on the size of the tumor. I think the cutoff currently is about 3 centimeters in size. Anything greater than 3 centimeters in size, there's no data to tell us if we can actually accurately control this. Now, don't give me studies with 3 patients or 2 patients. I'm talking of longitudinal studies of comparison with at least 50 to 100 patients in these studies. And the data is maturing. I think there are probably less than 100 cases that have been done across the United States. Even the first study that actually got the histotrypsy approved was a very small study. I think it was less than 15 patients, but it got its FDA approval. So I'm not against it. I think it's a great technique. I think in the near coming future, we will definitely identify which lesions we could approach with this. But if you've got multiple tumors within the liver, this is not the treatment for you.
Got it. Thanks, Pat. Next question from Eileen. Should enucleation for a sub-centimeter PNET be in the tail be considered, or must it be distal pancreatectomy? What size of PNET would trigger surgery?
Great. We've written papers on that as well. And actually, I will point you to the best paper written is actually a consensus statement in the journal Pancreas back in January of 2020. It's a consensus statement where 18 of our surgeons sort of met across the country and then laid down some guidelines. I granted it's about 4 years old, but a lot of those criteria still remain. So I look at not based only on the size of the tumor. I think age is an important factor in these patients, okay? So, and I'll break that down into two portions, size and age, and I'm going to tell you exactly what I mean by that. So if it's a tumor that's less than 1.5 centimeters in size today, the chances of it metastasizing are probably between 7 to about 14%. And when I say metastasizing, I mean to the local lymph nodes itself. So it's very low. So if you're 65, 70, 75, and you say, hey, I don't want surgery for a 1 centimeter tumor, I would completely endorse that. There's no reason to put you to a surgery where the risks outweigh the benefit of just observation. Now, when the tumor increases increases to about 1.5 centimeters in size to about 2 centimeters in size, you can make a case for surgical resection at that point. 100% for tumors greater than 2 centimeters in size, I would recommend resection, because once you cross 2 centimeters, the chances of having lymph nodes being positive is close to about 39 to 40%. So that means the disease has begun to move. So the gray zone becomes between 1.5 to 2 centimeters. And so I would be a little bit more proactive in that subset. Now, the question's very specific. Can you enucleate versus doing a distal pancreatectomy? So you're absolutely right. You can enucleate a 1 centimeter tumor in the tail of the pancreas. The caveat, the most important thing to remember is it sitting on the pancreatic duct, or is it on the surface of the pancreas? So if it's on the surface, it's easy to get in and take it off. You are going to end up with a small pancreatic substance leak, which is digestive hormones. But if it's sitting on the duct, you're going to disrupt the main pancreatic duct, and you're going to have juices flowing out, and the morbidity and the complications suddenly goes up to about 40% in this patient population. Okay, and so it is important to remember what is the location of that 1 centimeter tumor to the pancreatic duct. All right, now, would I operate on a 1 centimeter tumor in a patient that's 40 years old? I probably would, because we know that these tumors are going to increase in size. You can make a case to see what the rate of growth is. It's usually about 1 to 2 millimeters per year. If it's slower and nothing happens for 3 to 4 years, then you can make a case for observation and keep a close eye on those tumors. Because again, we are seeing more and more of these patients today. We at City of Hope here in Phoenix with our interventional GI folks are actually coming up with a study where we plan to use needle ablations of these tumors for these small tumors. You have to do them in small doses. You have to do it for tumors that are not close to the pancreatic duct. And we're planning to use, electroporation energy, which is not as destructive as radiofrequency ablation. So the chances of complications are going to be much lower. Having said that, it has to be done as a study, and it has to be because there's no data on it. The technology is there. Our interventional GI is on board, and they're phenomenal. So Dr. Kachami and Dr. Solomon here are actually working on actually getting that approved through an internal study so that we can start accruing patients for that. People have done ablations of these small neuroendocrine tumors. Those studies are well published. The results are encouraging again for small tumors, but the data is not completely mature at this point. I hope that answers your question. I know I gave you a long answer, but the most important thing, enucleation versus distal pancreatectomy, is based on the proximity to the main pancreatic duct. If you're not going to violate that and you're going to be able to get away without causing any damage to that and causing a big pancreatic leak, go ahead and get the enucleation done if it's not touching the duct.
Follow-up question, PNET question from Eileen. Are there treatments that are effective on PNETs with MEN1 tumor mutation?
That is a great question. Yeah, so there are certain drugs now that are available.
Okay.
But in MEN right now, anything less than 1 centimeter, we're still observing. Anything greater than 2 centimeters, we're recommending surgery at this point. There is emerging literature on MEN1, actually, even for there's this other genetic component with NF1 also, and not with TSC, but with VHL as well. There's a new drug. There are 3 new drugs that have been approved that have shown a lot of promise. I'm not the right person to give that answer for you, but those drugs are currently available. So if I wouldn't recommend using it to prevent growth. There's no data to suggest that it's going to make the tumor disappear, but you can use it as perhaps treatment for disseminated and MEN1 patients at this point. Good question, though. Very good. Somebody's really reading up on it, which I like. Yeah, because this is hot stuff. This is just
Yeah.
basically emerging in the last year, this data. Yeah.
Thanks, Eileen. Appreciate you. Next question from Shane. Following a liver debulking surgery for pancreatic net metastases, there was a growth 3 months after surgery, but subsequent 4-month follow-up then showed stability. Does intense surgery lend itself to growth spurts like this?
And so you're talking about growth spurts within the tumor itself. So I'm going to give you a more scientific answer on this. The growth spurts is what I think they're confusing with is the liver always regenerates 100% in volume. It's one of those organs that has the capacity of regenerate. So you can cut out 70% of the liver, and then basically the liver is going to regenerate close to 100% in volume.
Okay.
So the question often people say, is the regeneration going to cause a growth in the tumors that are existing within the liver itself? So the data on that is not 100%, but I'm going to give you the answer to that. So regeneration of the liver is dependent on a growth hormone that is internally secreted, which helps growth of the liver. The HGF hormone, which is a hepatocyte growth factor, which is responsible for the regeneration of the liver itself. Now, the HGF in itself does not affect tumor growth, okay? Now, having said that, you also have to remember in neuroendocrine, this is what I always tell my patients, if you have 30 spots in the liver, and I'm going in to clean these 30 spots out, it is a combination of usually surgery and ablation. Now, you also have to remember there are 30 spots that I can see. Does that mean there's no more disease within the liver? There is going to be microscopic stuff that I'm unable to see within the liver, which is probably going to grow. So it stands to reason that this patient population should get some kind of maintenance therapy afterwards. So if you have stability in the one lesion within the liver, don't panic. Just take a deep breath and continue enjoying life. I think it's very important to stay positive on it. And with neuroendocrine disease, I always say it is living with neuroendocrine tumors. It is living with this, making it a chronic disease, making it quality of life with longevity again. And I keep saying that, very important. You know, you don't want to steal the quality of life away by being super aggressive, but at the same time, you want to reset the clock so that you can control this disease in a long-term fashion.
Absolutely. Thanks, Shane, for your question. Let me know if you have a follow-up. Good to see you, by the way. From Susan, how many surgeries would constitute an experienced surgeon for resection of pancreas for a NET, for a neuroendocrine tumor?
So that's again a little bit of a tricky question, because if you end up at a community hospital, a place where they don't do a lot of these, they'll do them.
Mhm.
Okay. And it's not about nets. The problem is people will do pancreatic surgery for anything that maybe even assists sometimes. And they'll tell you, oh, I do a lot of pancreatic surgery. But I honestly think if the person is doing less than 10 pancreatectomies a year, he's not seasoned. Okay. And usually, I mean, there's no definite number. There are lots of studies that look at the number of nodes that a beginning surgeon takes out versus this and that. You have to remember surgeons are fully graduating from super specialty training where they've probably done over 100 with their attendings. But when they start off on their own practice, they're just beginning to start the surgical experience at an individual level. And it's not to say they're not good. Some of them are fantastic. I mean, I'll learn things from my younger colleagues some once in a while here and there and say, oh, that's a good trick, because science surgery is an evolution. All right. I would say I learned less from them today than I would have probably said 20 years ago when I started off. But it's a growth process. So I think you should definitely touch base with your surgeon and say, I mean, how many pancreatectomies, not for neuroendocrine tumors, but pancreatectomies do you do a year? So if he does anywhere more than, I would say, 5 to 10 a year, he probably has a reasonable amount of experience and is going to get busier with time. Most of us are really busy, do somewhere between 50 to 100. That's one a week almost, sometimes two a week. But then I also do a lot of liver work. So it sort of all balances out. We do a lot of work and we have a whole team that does it. So, you can end up doing, at some of these centers, you end up doing 200 pancreatectomies a year. So if you're looking at an individual surgeon, it's just experience, number of years behind him, and what's his complication rate. And you can ask these questions very nicely. You say, what are the complications I'm going to have? What do you anticipate my post-op stay is going to be like, et cetera, et cetera. And you can gauge his confidence level and comfort with it.
Got it. Thank you, Susan. Next question from Ruby. If carcinoid crisis is rare, should you mention it when having a procedure requiring numbing medications like lidocaine that's often mixed with epinephrine?
I actually like that question. I'm not entirely sure the answer on that. So the only time I've seen carcinoid crisis in surgery, even when you're getting into the belly of a patient with a neuroendocrine tumor, let's just say of the small bowel, and you're going in, often it's not when you're going in, but the moment you first handle the tumor, there is some kind of a mass histamine serotonin release that you see this drop in blood pressure intraoperatively. So immediately drop it right there, have the anesthesiologist give a bolus of octreotide and then put on an octreotide drip till you've taken out the tumor. And you'll be surprised by the time the tumor's out, that crisis almost completely goes away. For localized, where you're doing maybe a dental extraction or a local anesthetic or a skin biopsy, I'm not sure what the incidence of carcinoid crisis would be in that sort of a situation. That's a good question. The other thing, I don't know the numbers for that, so I wouldn't be able to tell you on that. The other thing is if you're already on a monthly shot of long-acting somatostatin, you're fairly well protected with these local anesthetic procedures then. But again, I don't know the right answer for that. So I would say don't quote me on this.
Got it.
I just
Thank
haven't
you.
heard of, sorry, pardon me, Rain. I haven't heard of anybody going into a crisis with a local anesthetic, although there might be case reports. I mean, it's prompting me to look after I'm done here today. Yeah.
That happens a lot. That happens a lot with this these conversations. So, thanks, Ruby. Let me know if you do have a follow up question. Next question from Suzanne. Any disadvantage to leaving two small tumors in the liver? I had surgery in 2016 to remove the primary and the ileum and metastasis, lymph nodes, peritoneal cavity, and I'm currently on monthly octreotide shots and Zermello. So the question is, any disadvantage to leaving two small tumors in the liver?
If they're stable, don't touch them.
You want to say any more about that?
If they're growing, then you can make a case to go after them. I would recommend the least, because this is now post-operative surgery. She's already had surgery on the liver. If these can be needled under CT guidance, then I would recommend local ablative therapy for these, because if there are only two, it should be easy to hit. And you can perhaps do both of them at the same time. especially if they're not sitting on any of the major venous pedicles or the blood vessels, basically.
Got it. Thank you very much. Interesting question from Jim. From all your statistical and research studies, has or at what point would you potentially see AI playing a role? Just that's the end of the question. So I guess that's a broad question about any role that it could potentially play in the future for this disease, whether diagnostically, sequencing. I'm not sure.
I think AI is a big player. Okay, what took us, a whole year to analyze, you can now put in algorithms for things and sort of get an answer within seconds. So AI is going to change, but the thing is going to be to develop algorithms and the equations to actually analyze what we're looking for. I think a lot of people are actually trying to develop these, even for helping patients when they're researching on Dr. Google, because Dr. Google can mislead you based on a lot of things. But the problem with AI is it's not perfectly accurate at this point. There is such a large error within it because the standard deviation can go, almost 30% on either sides or 40% on either sides, which is not an accurate measurement of how you would quantify or expect to be treated in a particular patient. There are certain things with simple electro physiological pulses and stuff like that, which are basic mathematical algorithms. Those will be first impacted by AI, but general questions will take time to standardize and get you crisper answers with time. We're not there yet, but yes, it will probably come there in the next 4 or 5 years.
Got it. Thank you, Jim, for that question. Next question from Samantha. Is growth the only way to determine if the lanreotide injections are not working anymore? If it isn't, would or could there be an increase in other symptoms such as pain, digestive issues, etc.?
So I look at growth, it's an important parameter, but when I first see my patients with neuroendocrine tumors, and this is what I've done traditionally, I kind of throw the kitchen sink at them. When I say I throw the kitchen sink at them, I do a huge battery of baseline blood tests, which includes a chromogranin level, a 5-HI level, a serum serotonin level, a neuron-specific enolase, pancreatic levels. So I do a whole battery of tests at the first clinical visit. And this is before they've had any kind of intervention. And then within those parameters, if I find one that is elevated, so for example, if 5-HIA is elevated, that becomes your best marker to follow this patient, okay? Because they will have subtle rises and subtle drops in this 5-HIA based on treatments. If chromogranin is your best marker, now remember, chromogranin is a little bit non-specific today because we realized that a lot of other things can impact chromogranin. But let's say if it was 2000 and after debulking it came down below 95, then it's a great marker to use. So again, a little bit of a long-winded answer, but what I'm really trying to tell you is growth is not the only parameter. If you have any biochemical parameters that are off, then I would use that as an equally important indicator to see if there's progression. I can't hear you, Rain. You're muted. I can't hear you, Rain, still. Yeah.
And now?
Yes, I can.
Okay,
Perfect.
lovely.
Lovely.
Yeah, my microphone got disconnected. Apologies, folks. We have 15 minutes left. We're going to keep plugging along. Dr. Singh, excellent job. Appreciate you being here. From Tony, my husband has tumors throughout his liver. Over 30 was what we were told, and his liver is severely enlarged.
Right.
Surgery has not been mentioned, but I would like to understand why that would not be an option.
Great. So not all liver metastases are cut alike. Okay. You need to know where these liver metastases are located, how many of these are resectable. If they're all over and they're sitting on the main blood vessels, then that particular patient cannot undergo resection. I mean, I've done up to 90, 95, you know, removals of tumors within the liver, provided I can achieve what I call over 70% reduction of tumor volume. Actually, this was a NASA scientist almost 10, 12 years ago, still rocking on and doing really well. So um, I think it's important in trying to answer your question specifically is to see a liver surgeon, okay, or a neuroendocrine surgeon, or a liver surgeon with a lot of neuroendocrine expertise, and then talk to the surgeon and see if this is something that can be debulked or not debulked. And if it can't be debulked, are there non-surgical approaches to approach that particular liver with either a combination of ablative techniques or embolization? So I think that there's definitely opportunity to control the disease. But the second thing is if it's stable on long-acting somatostatin, people would say, don't do anything at this point. If we see progression, then we'll go after it. And I think that's a great thing because you want to hold on to these therapies and use them only at the right time. And that's something that's not taught in medical school or in residencies or in fellowships where people don't see enough of this.
Hmm.
If you use everything at one time, you've lost everything. So you only want to use some of these treatments along the way in a sequential graded fashion. That's where I think, again, having a strong team is critical, or somebody with experience is critical on this.
Such a great point. I appreciate you illustrating it like that. That was really well stated, and I hope that helps. Tony, let me know if you have a follow up question. We still have time. From Mary, I know the steroids taken after a liver embolization can elevate glucose levels. Does or can the embolization procedure itself affect blood sugar levels?
Not aware of any data on that to substantiate that. So I don't think I have the right answer for something like that. Yeah.
Got it.
But if you've noticed that your sugars are dropping, just put it in the comment section. I'd love to know. If your
Yeah.
sugars are normalizing after you've had embolization and even you are on steroids, that's something interesting. Good to know.
hmm
Yeah.
hmm From Larry says, what sort of correlation have you seen between pancreatic nets and elevated blood sugar and A1C levels?
So, as you know, the incidence of pancreatic nets is going up. All right. Everybody knows that. And I just mentioned to you earlier that the UK, it's now the second most prevalent disease in neuroendocrine tumors in the UK after colorectal cancers. Now, nets do find themselves a little bit more common in heavier set patients. Okay. There are few smaller studies that show the higher the BMI, the higher the chance of having neuroendocrine tumors. Not strong data, so I'm not going to hang my hat on that. But the question you're asking is, can NETs cause type 2 diabetes?
Hmm.
The answer to that is no. I think type 2 diabetes in itself, unless it's a 10 centimeter tumor, then it's, of course, it's occupying more than 70% of your pancreas, then you're not making enough insulin. But if it's a very small tumor within the pancreas and you're making adequate amounts of insulin, then there's a discrepancy between the amount your body needs based on your BMI and your habitus versus what's being produced. Because not everybody's born diabetic. You become a diabetic because of type 2, which is, habits, diet, BMI, body mass index, BMI, are things that affect diabetes more. If there's a large tumor that's actually blocking and occupying a lot of the pancreas, yes, there may be an incidence of diabetes associated with that, for sure.
Got it. Got it. Dr. Singh, comfortable taking a lung net question that is surgical in nature?
Not my forte.
Okay.
Not my forte,
Okay.
yeah.
From Mary Kate. Mary Kate says, my daughter's malignant carcinoid tumor initially found in the appendix, cecum, and removed. Has continued to have difficult GI issues and flushing, heart racing, etc. She's being
Yeah,
treated with octreotide, with fair help of symptoms. She was 35 when it's found, now 39. Has been told at this point nothing has been seen in the liver or pancreas. Okay, sorry, I'm not sure if there's a question embedded in
right.
that.
Yeah.
Oh, quick question from Mylene. Any chance to get the name of the research study that Dr. Singh mentioned which showed consensus on surgical intervention, January 2020?
It's a pancreas study. I can give you the reference. It's in the journal Pancreas. It's a consensus statement. It was published in January, volume number 49. It just happens to be on my wall here on the side. So pardon me, because I even go back to it sometimes to look at the fine numbers. It is pages 1 to 33 in volume 49. Journal, the name of the journal is Pancreas, January 2020. You could The first author on that is Jim Howe, and I think the last author is Rod Palmier. So if you just did, Howe, Howe, or you did my name Singh, I'm somewhere in the middle of that authorship there, and did consensus statement, it should pop up on PubMed.
I think I've heard of those other folks as well, a couple
They're
times.
all they're all great guys. Yeah, all of them are great. Yeah, I mean, I've always learned from people I've worked with, and that's the joy of medicine, I think.
Absolutely.
And of course,
And with this community being so kind of tight knit, right? I think it's
yeah, yeah,
everybody learns from everybody.
for sure.
Thanks, Eileen. Hope that helps. From Catherine, does many episodes of hypoglycemia while being treated for carcinoid syndrome with lanreotide point to a particular location when the dotatate PET scan does not show a tumor location?
Can I request that patient to do an endoscopic ultrasound of the pancreas? Because repeated hypoglycemia is often associated with an insulinoma.
Mm.
And sometimes, so it's a functional tumor. And if it's less than 1 centimeter in size, your CT and MRs are not going to localize it sometimes. So I would push you to get an endoscopic ultrasound to make sure that the pancreas is completely clean. Now, you can have non-pancreatic functional areas of tissues, but that's if your dotatate is not picking that up, then it's going to be hard to find. Even with an insulinoma, sometimes the dotatate scans are not picking up these very small tumors. Okay, so I know we should be able to localize them, but I don't think it's 100%. So I would encourage you to get an endoscopic ultrasound of the pancreas to make sure there's no functional insulinoma that's hiding anywhere there.
Mhm.
The other thing to look at, you can also have a functional insulinoma within what is called the gastronoma triangle. They're the highest. So it could be in the duodenum, it could be in the end of the stomach, and the starting of the small intestine. So your GI guy can actually look inside and make sure that there's no functional tissue that might be in your neuroendocrine tumor that's actually hiding. So I'd encourage you to get that.
Thanks, Catherine. Hopefully that helps. From Shane, do you think liver mets, metastases, have the ability to spread cancer, or does that just come from the primary?
It always comes from the primary. Okay, liver is the biggest filter in the body. The intestines, entire pancreas, stomach are all draining through the liver. Okay, it's 1.5 liters per minute of blood flow through the liver. Our entire blood volume is about 5 liters. So within 3 minutes, it's filtered the entire body basically. Now, the beauty of the liver is over 99% of the times, it is actually able to get rid of these tumor metastases and these tumor cells. So that's why not every patient with neuroendocrine disease ends up with liver metastases. But sometimes they find the perfect environment and then they start growing. And unfortunately, those patients do develop liver metastases. The question I think you're trying to ask is, can the liver metastases send metastases to the lungs or somewhere else? Don't know specifically whether the liver is actually sending those out or whether those are still circulating within the system that are getting trapped in the lung or other tissues. Okay.
Okay, folks, we've got 5 or so minutes left. Let's keep moving forward. From Tony, is bland embolization an effective follow-up to liver met and debulking?
Yes, it is. Yes, absolutely. And again, this should be a good discussion at one of your tumor boards to see whether bland embolization should be preferred over Y90. I definitely am a proponent of bland embolization because Y90 is, or yttrium-90 is a radiation molecule. So there is a little bit of collateral damage with that. So depending on the tumor that's increasing in size, the amount of residual good liver that you have, sometimes I do say, why don't we just bland embolize this one big tumor that's increasing in size and everything else is well controlled? And then use that as a strategy first before running to using yttrium-90.
Got it. Thank you for your question. Next question from Samantha. 4.4 centimeter non-functional tumor in the body of the pancreas. Regional lymph node involvement wrapped around the main hepatic vein, but no infiltration into the vein. Would you feel comfortable resecting it with your experience in general?
So it's not hepatic vein. I find that difficult to understand. Is it? It's in the body of the pancreas, correct?
Body of the pancreas, regional lymph node involvement wrapped around the main hepatic vein, but no infiltration into the vein.
So there's something not right in that. It's probably wrapped around the main splenic vein,
Mm-hmm.
not hepatic vein, because hepatic vein is above the liver and
Oh.
it's an outflow out of the
Mm.
liver to the heart. So the pancreas is much lower down in the body. So I think it's probably splenic vein that she's talking about. And yes, definitely, if it's resectable and the major, you can get a good distance on your blood vessels, definitely resect it, please.
Got it. Thank you. Next question from Janice. I am taking Creon for my 3 tumors in my stomach and I'm receiving lanreotide shots. I'm in the 4th stage. The question is, should I have surgery?
Um,
Or what
that's
should
a,
be
that's a
considered for that?
great, yeah, that's a great question. So again, when you say 3 tumors, so there's a very specific question, so it's a little tricky answer.
Okay.
When you say you've got 3 tumors within the stomach, is it within the stomach, within the pancreas, within the intestines, or are you generalizing stomach here in this case?
There is a follow up. I
Yes.
had a 22 centimeter tumor in MT tumor. I have had this for 4 years. There's some typos here.
Yeah.
Yeah, yeah. I don't think we have the information that we need,
Yeah.
unfortunately. Janice, if you're still there, um, try to give us a little bit more clarity. We want to try to get you an answer if we can. From Grace, in the meantime, is it risky to get octreotide dosage reduced from 30 mgs to 20 milligrams after 4 years of treatment and the disease being stable?
Shouldn't be dangerous. Shouldn't be dangerous. Yeah. It's a pretty much, we tend to go up on the dose of octreotide. We used to traditionally start at 20, then go up to 30, then 40, then 60. So I think if you're very stable and you want to drop it by 10, it should be a discussion with your medical oncologist.
Hmm.
And then again, keep a close eye when you're dropping this down to make sure the stability has not changed. But my question in reverse would be, why do you want to drop that by 10 if you've got great stability? Why rock the boat?
Hmm.
So I would encourage you to probably stay status quo because again, nobody knows the answer to that specific. But if you're going to do it in a controlled setting with your medical oncologist.
From Kaylee, hey, regarding markers, can a patient have high histamine or substance P but normal chromogranin A, 5-HIAA, and still be an indicator if all symptoms were matching, including flushing of carcinoid syndrome slash NETs?
Yeah, the answer is yes.
Okay.
So you're really focusing on the ones that are high indicators because the chromogram can be completely normal. And I have seen that. And in fact, I've actually compared the studies with 5-HIA levels elevated, the chromograms are normal. And I tend to use a 5-HIA in my follow-up with these patients. A little bit painful because it's a 24-hour urine collection. The serum 5-HIA test is now available, but has not been completely standardized in follow-up in this patient population.
Got it. Thank you very much. Appreciate your question, Kaylee. Dr. Singh, what right now, there's a lot of flurry of activity, I would say, in the past few years. What are you excited about most that coming down the pipeline that will help you do your job more effectively?
So, I always say if you can put a surgeon out of business, you're doing good. All right. And I really think, I mean, I don't want to be out of business, but it doesn't matter if we can cure cancer at the cost of putting some, taking away surgery from these patients, it would be great. So I am looking forward to a few good targeted molecules. We do know the somatostatin receptors exist. And if we can get some good targeted molecules for these somatostatin receptors, which are present in over 80 to 90% of these patients, we personally been working on something for about 10 years. I've been working with John Williams and Tiana Talisman on the main campus at City of Hope. And, we have to go back to the drawing board every now and then because we don't have the greatest animal models to study these treatment forms in. So we have to do a lot of this in vitro, which is in the Petri dish. But I always like to say, keep an open mind. I think there are a few drugs coming down the pipeline, whether it's going to be 2 years, it's going to be 5 years. I think we've got to find an answer for this. And I'm excited, always it's always riveting. I find science always, no time in science is wasted time. I look forward to some of these therapies coming out and helping so we can debulk a major tumor and then control the rest of the disease with these, targeted antibodies or targeted products that are being developed today. So I think we at City of Hope are quite at the cutting edge on this, but we're not there yet. I'll let you know the moment we have more.
Thank you very much for that. And thank you for being here. That's the end of today's show. Dr. Singh, I appreciate your time so much. Tom says, thank you for the honest and clear answers, Dr. Singh. I agree. You've been very straightforward, and the way you've explained things has been very helpful and thoughtful and thorough, but also very clear. I appreciate that very much.
Appreciate you having me. Thank you for the opportunity to talk and serve the NET community.
Absolutely. And folks at home, we thank you for being here as well. And as always, we hope the program helped answer some of your questions. Again, I'll reiterate, you can always reach out at lacnets.org/support line for any follow-up questions. And of course, we'll be back in 2 weeks. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. Finally, my name has been Rain Bennett. I've been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.